Good evening, everyone, and welcome to tonight's CPD webinar, Responding to Sexual Violence in Primary Care. My name is Janina Beckmann, and I work as a Domestic Family and Sexual Violence Program Officer at Central and Eastern Sydney PHN. Pardon me. I would like to start tonight by acknowledging the traditional custodians and sovereign people of the lands across which we work. I recognize their continuing connection to land, water, and community, and pay my respects to elders past and present and emerging. And I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. For housekeeping tonight, please submit any questions you may have into the Q&A function at the bottom of your screen. We will have time for questions at the end of the panel discussion. We do not have the chat function enabled during the session, but we have the Q&A function enabled for you to submit questions. And I would also like to introduce our speakers for tonight. So we have with us Dr. Jennifer Martinez, one of our GP educators here at the DFSV program at CESPN. Jennifer is trained as a GP, and she currently works as a staff specialist and is also the head of the department at the Sexual Assault Service at the Royal Prince Alfred Hospital in Camperdown, which is the state's busiest department. She oversees the placement program to train out-of-area forensic nurses at the New South Wales Health Education Centre Against Violence. Jennifer unwinds by immersing herself into a horror movie or a book. And at home, she's the ringleader of a lively household that includes her husband, 4 teenagers, and a rescue pit bull, who's probably the most relaxed member of the family, as she has let us know. We also have with us Anna. Welcome, Anna. Anna Coutts-Trotter, who goes by the pronouns she, her, is a co-founder and director of the Survivor Hub. Anna is very lucky to currently live and work as a social worker on beautiful Wilyakali country, which I understand is out Broken Hill Way. Anna experienced domestic and sexual violence as a young person and endured an isolating court process as a result. And Anna was inspired to create the Survivor Hub to empower connection and community between survivors. Anna believes that healing can only happen with connection and support from other people who just get it. And as a recent graduate of the Bachelor of Arts of Social Work, pardon me, from the University of Sydney. And Anna was recognized for her work with the Survivor Hub in 2023, being named Westfield East Gardens Local Hero. She's an ambassador for the National Survivors Day and has worked with Full Stop Australia, Bumble, Anne Rose, Our Watch, the New South Wales government, and others. So wonderful to have Anna with us tonight. And we also have with us tonight Robyn. Robyn Laughton-Smith is a social worker with 25 years experience working in government and non-government roles in Canberra, Sydney, Perth, and London, with a focus on the well-being of women and children and their experiences of violence, abuse, and neglect, including domestic violence and sexual assault. Robyn is focused on survivor-led patient-centered care, and she has worked with families pre- and post-child protection services, including a statutory role in child protection. She has extensive experience in the New South Wales service system, and Robyn provides support to primary care providers, which we will hear more about later, to ensure patients receive all that is available as a sexual violence and child sexual abuse navigator for CESPN. Just one more thing before we start. As much as possible, we will aim tonight to use safe talk throughout the discussion, but we can almost be certain that the issue we will discuss will have been experienced by some of the people in this room tonight. So because of this, some people might find the contact confronting. And if you would like to take a break, please do so. Step away, do something good for yourself. Remember also that there's numbers that are available, and you can also reach out to myself after the webinar or to my colleague Lauren Gessock, who's also online tonight. We are also here to respond. And with this, I'm handing over to Dr. Jennifer Martinez to take us through. Thanks, Jen.
Thank you very much, Nina, for that very generous introduction. And welcome to everybody who has joined us online tonight on a Wednesday evening, probably after a very hard day at work. So I just want to acknowledge the PHNs involved in creating this presentation to which I will be speaking to. And I guess at the end of tonight's session, hopefully what will happen is you'll be able to recognize the signs and indicators that may suggest a person is experiencing sexual violence. You'll understand how to respond in a supportive, appropriate manner if someone discloses this type of abuse. So then that way you can act confidently and sensitively in the moment, which is very hard to do if you're not used to it or you haven't done it before. And finally, you'll be able to identify support services and resources available to ensure that those affected can access the help that they need. So we will be defining what sexual violence is. We'll be talking about stats to improve our understanding. But really what we'll be doing is centering on the primary care response, which is to recognize, respond, and then refer, and a little bit more on self-care. So to respond effectively to sexual violence, it's important that we clearly define what that is. So sexual violence is any act where someone is coerced, manipulated, forced, or unable to consent to a sexual activity. And it includes behaviors like sexual touching, penetrative sexual assault, rape, stealthing. Stealthing is removal of a condom without consent. Having sex without clear affirmative consent, or performing a sexual act that wasn't agreed to. And that can include things like non-fatal strangulation. So prior consent for one act doesn't mean that consent for everything, doesn't mean consent for everything or for all future acts. Another thing to keep in mind is sexual violence also covers non-contact behaviours. So that includes things like making someone watch pornography or using someone's image to create AI pornography, taking or sharing sexual images without consent, not telling a partner about a known STI before sex. So it's very all-encompassing, this term, sexual violence. But at its very core, sexual violence, similar to domestic violence, is always about an abuse of power. So every form of sexual violence, it really does cause very real harm. And I guess this slide exemplifies why the issue is so important. 22% of women and just over 6% of men have experienced sexual violence since the age of 15. So when it comes to unwanted touching, grabbing, or kissing, those numbers jump up to 57% of women and 51% of men. So it's obvious that sexual harassment is widespread and nearly as common for men as for women. But really the most striking thing here is that 92% of women who experience sexual violence by a male did not report the most recent incident to police. And these numbers show that sexual violence and harassment are far too common, and most of it remains unreported and unseen. So what I'll do now is I'll share a video produced by Full Stop Australia once I get this up and running. And I guess it's a short video that showcases survivors and their experiences. And as Nina mentioned before, we have a lived experience expert, Anna, who'll be on our panel tonight. And it's their experiences which will deepen our understanding of the impact of sexual violence. And they remind us why our work is really, really valuable.
We're here to put a full stop to sexual, domestic and family violence, and we do this through supporting survivors, equipping organisations and advocating for change. But we can only do this with your support. Have a listen to these survivors' experiences and their thoughts on what each of us can do to play our part.
It takes such a long while to come to terms with things, particularly when it's abuse that happened since you were a child. Like, you don't know any other reality.
No one should have to experience violence of any kind.
I went through a massive amount of victim blaming. Things like, why didn't you fight harder? Where were you? What were you wearing?
I know for a fact if I saw a man in the media talking about what I'm talking about now, that could have saved my life. So I could be for the little boy today what I needed at the time.
I was told by my perpetrator that these incidents of unwanted sexual contact and sexual touching in the lead up to an attempted rape were my fault, and they were only happening because it was my idea. And the fact that I'd had a freeze response meant that I must actually want it.
Every profession should be safe. And there's no difference whether I've been sexually assaulted as a waitress, working at the office, or as a sex worker. It should have never happened at any of those workplaces. I also recently found out that I am autistic, ADHD and dyslexic. Before my diagnosis, it was really easy for someone to convince me that they pushed me because they are my friend, or this is happening to me because they are nice, and that it's actually me who is doing something wrong, and that I am impolite.
I think we need to recognize that women and girls throughout their lifespan, from birth to death, are vulnerable to sexual assaults. There are 50 sexual assaults taking place in aged care in Australia every week. Nobody believes them. Nobody believes that older women in aged care can be sexually assaulted because they're not seen as sexual beings.
I felt that I didn't stand a chance. My parents wanted for me to have an arranged marriage. You know, the word sex was never said.
I remember sobbing really hard and going to the room where my parents are sleeping, and they were asking me so many questions, but I wasn't coherent, and all I wanted was my mom to hug me. And she seemed, I guess it might be intergenerational trauma, but she seemed like she couldn't really do it, so I physically took her arms and put it around me to try and feel better.
I also wish, as a child, that someone noticed any of the signs of a child going through abuse, and I wish that someone called the police or called Child Protection Services.
Talking with the Full Stop Helpline has been such a life-saving thing.
Flood society with help. There should be more centres for therapy than there are McDonald's. You know where to get a cheeseburger, but you don't know where to get help, you know?
So whether you're a survivor or not, you know a survivor, this issue affects everyone. It's an issue that needs to be spoken about, and amazing organisations and charities like Full Stop Australia are doing this and doing this every day.
I'm still alive. That's the impact, really, the fact that I'm sitting here. That's the impact.
So that video is very, very powerful, and I still get a little bit emotional every time I watch it, even though I've seen it quite a few times. So,
I was just thinking that too, Jen, that I was just thinking that too, that such emotional impact from hearing those stories and how important it is to really centre the information and the wise knowledge that we receive from that.
Exactly. And they made it really clear, you know, in regards to how we respond, really, it changes the trajectory of someone's life. So, in regards to sexual violence, we know that it's fundamentally rooted in power imbalances. And while women and girls are disproportionately affected, we should recognize, it's essential to recognize that anyone, including men and boys, can be a victim. And really, vulnerability, it's shaped by factors beyond gender alone. And certain groups face even higher risk. So that includes people with disabilities, those in aged care or institutional settings, our culturally and linguistically diverse communities, and individuals with a history of prior violence. And these risks are a result of systemic issues like discrimination, disbelief, social isolation, and dependence on others for care. So it's not just chance. For example, women with disabilities in Australia are twice as likely to experience sexual violence as those without a disability. And the risks escalate in institutional contexts. And so research has found that as many as 50 women are sexually assaulted every week in a residential care setting across Australia. And so these statistics, they highlight why it's crucial to understand and address the power dynamics and barriers that expose some members of our community to greater harm. And recognizing these contexts, it really empowers us to spot early warning signs, to be on higher alert, and to better support those who are most at risk. So it's critical to have a clear understanding of consent when discussing sexual violence. And there have been a few changes in legislation that have happened over the past several years. So just to remind everyone that consent must be given freely by someone who has capacity and has communicated through words or actions. So silence or lack of resistance doesn't count as consent. So very important to understand. And the law also says that there is no consent when a person is asleep, if they're unconscious, if they're too affected by drugs or alcohol, if they've been pressured or coerced or deceived. And in something in relation to age of consent. So under New South Wales health law, the age of consent is 16, which means anyone younger is legally incapable of consenting to sexual activity, even if they say yes. There are some exceptions to this. So if both people are willing and close in age, a 14-year-old may consent to someone no more than 2 years older. And also kind of on the other end of things, if a young person is under the special care of the other person, such as a teacher or a coach or religious leader or carer, the legal age of consent actually goes up to 18. So this recognizes and it protects against abuse of power in these types of relationships. So a little bit more in regards to improving understanding and just understanding disclosures from victim survivors. You know, sexual assault myths, they are very widespread and they make it very hard for victim survivors to come forward and seek support. And these myths really feed the shame and the silence, and they stop people from reporting or disclosing abuse. So to address this, the recommendations really call for a better understanding of what survivors experience. So some key points to emphasize is that disclosure is often delayed. And there's lots of factors for this: confusion, guilt, fear of not being believed, or internalizing blame. That all leads to silence. And it's only 6 in 10 women will seek help from anyone after being assaulted, and only 13% report to police. And we all know that conviction rates are extremely, extremely, extremely low. The other thing to keep in mind is victims can be people of any age. And as I mentioned before, there is data that shows rising violence against older women, and that kind of it highlights the importance of normalizing these kind of conversations across all ages and genders. False allegations are rare. So less than 5% of sexual crime reports are false. And most of them, if they are false, there's usually a reason for it. And it may be out of fear or to seek help. It's usually not out of malice. And like I've said before, the shame and fear of disbelief, they're very, very common. So it makes our response very crucial. How someone should respond after sexual violence is also still surrounded by myths that influence our society. And these beliefs lead to harmful judgments, and they stop survivors from seeking help. And they also actually affect whether or not justice is received. And interestingly, in Australian courtrooms, the judge will give specific directives that address these myths to the jury. So they give mini lectures in sexual violence cases to address myths. So, for example, freezing or fawning are common. They're probably the most common responses a victim survivor will have. So fawning is also known as friending, where someone will go along with the perpetrator out of fear, and it's a survival response, and it's an automatic reaction. And so this is part of why affirmative consent laws exist, namely because most people don't fight back. The other important thing to note is memory after trauma is very, very rarely neat or linear. So details may come out over time. It's often really fragmented as well.
Just to comment on that too, Jen, I had a conversation with a GP this week, and that added layer, I guess, that you were sort of saying is sometimes termed friending, was really coming through in what the victim survivor was saying to the GP. This is something I pursued, you know, this is a relationship that I wanted. And when more of the story came out, it had begun at 14 when the person causing harm was their tutor. And the way that people are groomed and the way that sexual violence can occur in some of those ways leads to, you know, this, as you said, this really common part of the response is this fawning or freeze or sort of friending.
Yep, exactly, Robyn. And the last myth to mention is that the emotional responses really differ between victim survivors. So some will cry, some will shut down. A lot of them will seem extremely, extremely calm. But none of these responses make their experience less real. So, you know, I hope that we all remember we are doctors, and our words really carry influence. And I guess in regards to these myths that I had mentioned, it's quite widespread in society. Correcting misinformation, it not only helps survivors feel heard and supported within our clinic, but further to that, it shapes more compassionate and effective responses within communities. So what I'm trying to say is we should really actively address myths about sexual violence whenever we encounter them. And that might mean gently challenging friends or family, or even patients. And just a little bit on understanding perpetrators of sexual violence. So the majority of sexual abuse is committed by someone the victim knows, and that's commonly a relative, a friend, a neighbor, a partner, or a housemate. And abuse by strangers is much, much less common. And I guess while approximately 90% of perpetrators are male, there's no single typical profile. So perpetrators come from all backgrounds, all ages, and all communities. But having said that, boys and young men aged 15 to 19, they represent the highest proportion of known perpetrators. And I guess that raises important questions about early intervention and the social messages received by young men. The other thing about perpetrators is they tend to be strategic in targeting vulnerable people. So they choose victims perceived to be less believed or who may have a heightened dependence, such as those people living with disabilities or in care. And a recent study found that about 1 in 5 Australians self-reported being perpetrating some form of sexual violence. And sexual violence, like I mentioned before, it takes many forms. So from pressuring someone into sex or dates to recording and sharing intimate images, as well as overt sexual assault and rape. So crucial to remember that perpetrators are also people we encounter in clinical and community settings, and many don't actually realize they are perpetrators. So these discussions are really important for effective support and prevention. So this is really the focus of the session, which is the primary care response. This is where you make a difference, and we want you to be able to feel comfortable to respond to suspected or disclosed sexual assault, and to know the signs. We want your response to be person-centered. So by person-centered, we mean with respect and empathy, but also trauma-informed. So you hear the word trauma-informed thrown around quite a lot, but what that means is, as well as the respect and empathy, which we should show all our patients, trauma-informed is to give these people that we identify that safety, that choice and empowerment. And then you'll also be able to know where to refer for support when there is consent for a referral. So in terms of recognising, there are certain social and mental health and medical signs which flag increased vulnerability. And these include things like intellectual, developmental or physical disability, social isolation or unstable living environments, if there's a history of substance abuse, or if they are a person that belongs to a minority or a marginalized group. And then certain health patterns can flag increased vulnerability. And they're the things like chronic pain, like fibromyalgia or undiagnosed pelvic pain, undiagnosed abdominal pain as well, persistent mental health issues, and just frequent unexplained symptoms with repeated healthcare visits. And we all have patients like this. And in medical literature, we they're referred to as heart sink patients. The other things that you may recognize or notice are avoidance behaviors. So that would be things like reluctance with certain exams or procedures, especially things that involve touch, or resistance to or being really uncomfortable with having to do the cervical screening test. Anxiety or dissociation or distress during normal routine clinical care is another behavior to watch out for. And just regularly missing or cancelling appointments as well is another kind of red flag. I just wanted to touch a little bit more on heart sink patients, which I mentioned. So just for those who have not heard of it before, they are patients who trigger that sinking feeling when you see a patient's name, and they are someone that you've not been able to help. They often present with very persistent symptoms and with frequent visits. And that reaction is very common for all of us. But it's very important that you see it as you kind of shift the blame. So instead of them being heart sink patients, it's really we are experiencing the heart sink. And it should be a signal for us to shift gears. So we have to increase our curiosity. And then, by that token, heighten our suspicion of trauma. And that will activate your capacity for trauma-informed care, and you may actually get to the bottom of their presentations. So after recognizing the signs, we'll respond in a trauma-informed way. And so that trauma-informed care basically begins with that physical and emotional safety. So you want to think about, from the very beginning of when your patient steps into the clinic is like, how does your clinic welcome patients? Is your space reassuring? Is it not intimidating? Do you have practice policies that actively build trust? Is there clear confidentiality? Things like transparency are quite important, checking in with patients, asking how they're feeling. Trauma-informed care is empowering your patients with real choices, where you invite them to guide referrals. Patients are quite good at navigating the internet and doing their research. Let them become partners in care. Let them steer the conversation and participate in decisions. And you want to really just move beyond just doing things for them or to them. You want to focus on doing things with them. So every step that offers control and dignity and respect, that it does help restore a sense of safety and agency. And then from there, you can start to explore.
One of the points on collaboration there too, Jen, is the possibility at times to collaborate with the client, yes, with the patient, yes, but also with the people around the patient, where you're able to check if things were deteriorating for you, how would I know? And who do you give consent for me to contact, so that your care, providers could be more supportive of you at a time that you're, in more distress. And some of those ways of trauma-informed care response helps to sort of lift people higher off that crisis low in an opportunity.
Absolutely. Thank you. So specifically in regard to responding, it's actually very good to have a scripted response. And it's awkward the first few times you ask, usually to yourself, and usually the patient won't notice because they're too focused on themselves. And if they do notice, what we do know from studies is that they appreciate being asked rather than not asked. So a script is absolutely the way to go for anyone here who has not been able to make that leap to ask a question if you've suspected something, because it is very difficult. It's very easy to suspect something and then just feel so awkward that you'd rather just ignore it and move on and hope it goes away. But we know it doesn't go away. So in regards to the questions you ask, you can ask, funneling type questions. So you start from very generic questions, like you seem a bit different today. Is everything okay? And then you gradually, if you feel it's okay to, then you can make the questions a bit more specific. And things like normalizing the question is very, very useful. And I use that quite a lot when I see a patient who presents to hospital specifically for a sexual assault. I normalize almost every single question that I ask. So so they don't feel singled out. The other kind of questions that you could ask is, has anyone ever forced you to do something when you didn't want it? Usually, if a specific situation has come up and they mention a person, obviously you would ask if that person has forced you to do something you didn't want. Or sometimes you can just ask if they're not being very clear, if they've disclosed that, say, sex has happened, but they've not made it clear that it wasn't consensual. You can just ask. A lot of people feel pressured into sex. Was this something that you wanted? And usually they will say, no, I didn't want it. And then you know it's not consensual. And then just them saying it out loud and you validating it makes the world of difference. So on that note, because you have taken a trauma-informed approach and you've been curious, and your patient has disclosed sexual violence, the next thing is to respond to that disclosure. And And the most important thing that you can say is, this is not your fault, and that was wrong. And that will make all the world of difference, because they've come into your room, or they've come with, this experience that they've carried with them for, days, weeks, years, where they've thought it is their fault, and they've been gaslit into thinking it is their fault. And for someone like yourself, a doctor who they hold in very high regard, to say it is not your fault and it was wrong is very, very powerful. And you see it, you see the relief immediately. So if you do this well, if you respond well, you will reduce the long-term health impacts of violence on this person. Now, I don't really have to say this, but, we want to avoid questions or statements which diminish what's happened or suggest blame. And sometimes we will do it just out of habit. For example, we might say, at least you're still here today, or something like that, because you feel like you need to say something to minimize what's happened. Don't say that, just sit with our own discomfort. And also try and avoid any kind of questions, especially this probably relates more to recent sexual violence. Don't ask questions focused on if alcohol or drugs was used, or what their behavior was like before it happened. It's not relevant. And look, if they don't want to discuss, that's okay. And you can acknowledge it, and you can just say, look, I can see you don't want to talk about it, and that's okay. And I am here if you ever do want to talk about it. And then obviously you can make the focus around medical care, clinical care as well. So that brings us on to the next slide. Apologies, my computer's lagging a little bit. Depending on when sexual violence happened, like it might be historical, it might be quite recent. Depending on when it's happened, you want to do just an initial kind of safety assessment. That's quite important, because that will inform what you do next. And you want to consider if there's any specific medical needs to be addressed in that consult. So ask yourself, is it appropriate to do any kind of physical examination? And usually it's not, if you're thinking of sending that patient to a sexual assault service for, say, forensics. And just to give you a time frame, it's 5 to 7 days after a sexual assault is when they can be seen, specifically for medical and forensic care in a hospital. The other things to think about are STI screening. And that STI screening is more opportunistic screening. So it may not actually pick up STIs related to an assault. But what we know is people vulnerable to sexual violence are more vulnerable to STIs, and that's why you're doing the STI screening. Think about pregnancy, like emergency contraception, and other STI prophylaxis, if that's something you are authorised to prescribe as a GP. So for things like HIV, we don't do prophylaxis for chlamydia, gonorrhea. We only treat that. And then the other things that you want to think about is follow-up, where you want to follow up with this person within 2 weeks. So if this is a recent assault I'm talking about. And if you are thinking of making any kind of referral to services, warm referrals are the best way to do that. And by warm referrals, we mean you or, or your nurse, someone to make contact for the patient to organize that appointment and to send that referral through with enough detail so the patient, the client is not forced to retell their story. You also want to consider completing something called a certificate of injury form for your patient, and that will enable your patient to access, I think, up to 22 hours of counselling through victim services, and that's separate from the Medicare Better Access Scheme. And there are local services that can help patients with these applications, and we may speak more to that later on. So on the screen right now, we have a screenshot of the certificate of injury form, but we also have a screenshot of an online portal called the Sexual Assault Reporting Option, which is also known as SARO. It's actually not many people know about this portal. It's available to anyone 16 and over. And the SARO portal basically allows someone to complete an online report in regards to sexual assault. They can choose if police can contact them or if they want to remain anonymous. It's not a formal police statement and it doesn't trigger like a criminal investigation. The main purpose is to record what has happened. And so it can be useful in instances where there may be multiple reports of the same perpetrator, and police might make contact only if the reporter has given consent. And it's also a good brain dump for people who have experienced sexual assault, and the process itself can be therapeutic. So something to think about if you have a patient who doesn't want to report to police for very good reasons. They can think about using SARO. So you can just Google that and that will come up. And just a reminder for any young people under the age of 18, if you're unsure if something it needs to be mandatory reported, just err on the side of caution and use the mandatory reporting guide. Just a note on documentation. So any clinical notes that you have related to sexual violence, you should keep that as a confidential record. And they should be, flagged as separate sensitive content. Which might mean actually putting a warning on the records if that's something that your software is able to do, and just make a note that it's privileged records. And sometimes if a sexual assault case does go to court and you have made notes, you may actually be subpoenaed to provide records or evidence. for a case. So your documentation should be, well, first of all, you need to be transparent with the patient, and you should have consent before you record anything. Reinforce the confidentiality, and when you do when you do document, try and be very objective. You can write verbatim what they've said. Try not to translate what they've said in your own words too much. Remember that the notes are designed to help the patient. It's actually not a police report. You're not doing a police report, but when you're writing notes, you need to keep at the back of your mind that they may go to court. And it is important to document the harm that was done to that patient. That documentation of harm. You as a medical practitioner are well within your scope to write down what the patient has said in terms of harm. There is something called, in New South Wales, something called the Sexual Assault Communications Privilege, which actually protects confidential communication, like counselling notes, from being disclosed in court. So that's also something to keep in mind. It's a bit outside of the scope of tonight's talk, but you can Google that if you want, or read up more about that. It's a Sexual Assault Communications Privilege.
Yeah, so this slide relates to the role that I have in the district, the primary health network for Central Eastern Sydney, Sexual Violence and Child Sexual Abuse Navigator. So the position is funded really to be available to primary care providers, and these things we've listed here. We visit practices. This type of training we're delivering tonight, we can deliver within your practice, and we contact practices to make this available. Sometimes it's a lunchtime training, or it can be an online webinar like it is tonight. We are available to discuss the cases that you're seeing where your concerns are there, and you just need to have that extra reassurance that what you've covered, where you're going, or when you have a question mark to do that. And we can also talk about what might be available for what your patient needs in the services in the community, and how they might access that. So we're really there, that link between primary care providers and the sexual violence, child sexual assault sector. And as was mentioned before, in the context of domestic violence, my colleague is a domestic violence navigator. So both of us are available across this topic, whether it's within the context of domestic violence or sexual violence and child sexual assault. And those details are also on the CESPN website if you need to find that as well. We can be emailed or phoned on that number. And we'll come to more of that in the panel discussion as well. Thanks, Jen.
Thanks, Robyn. Yes, so such a valuable resource. It's very difficult, navigating the domestic and family and sexual violence space. So yes, amazing service to have. As well as having Robyn and team to phone a friend in regards to resources, you can also call your local sexual assault service for for advice as well, and we give advice to GPs all the time. I'm not going to go into forensics into too much detail. The main things to know is if you're unsure, health pathways, as you all probably use quite often, is where to go to look up specifics in regards to forensics. Or you can call us as well if you have our number is more accessible than health pathways. In terms of timeframes, like I mentioned, if the assault's happened in 5 to 7 days, medical and forensics team can respond. In terms of sexual assault services, yes, there are lots of hospitals across Sydney, across central Sydney and eastern Sydney, but there are only sexual assault services in RPA, St. George Hospital and North Shore. So if you want to refer a patient for forensics or counselling as well, or the counselling service, so anyone who's experienced sexual violence within the past 14 days are entitled to a crisis counselling response. Please refer them to either North Shore RPA or St. George. Otherwise, if you refer to Prince of Wales or St. Vincent's or Canterbury, they will then have to be transferred from that hospital to us. And just a quick note on the forensic response. It's what we call a joint response. So when a patient comes to ED, we try to respond within the first hour of them presenting, and that response is by a counsellor and a doctor, and we see that patient, and usually the assessment takes about 2 to 4 hours. So it is a long process, but a very therapeutic process, and we find patients feel much better for coming. Just see what the next slide is. Health pathways, which I'm sure you're all aware of. QR code is on the screen if you want to screenshot that. And Nina's already spoken about numbers for self-care. It has been a very heavy session. We still have a panel to go through, so I'll just stop sharing, and Nina, and I'll hand over to you.
Thank you, Jen. Thank you very much. If you can go back to sharing them, then maybe it helps people to read along the case study. So we would like to talk now on our panel is comprised of Anna and Jen and our sexual violence and child sexual abuse navigator. So I'll read the case study that we have prepared, and then we'll ask some questions to hopefully get a bit more insight on the topic. So Sophie is a 32-year-old woman who presents with persistent fatigue, headaches, and intermittent abdominal pain. She reports feeling anxious and having difficulty sleeping, but attributes these symptoms mainly to work stress. Sophie is somewhat withdrawn during the consultation and briefly mentions feeling overwhelmed in her personal life, but doesn't provide any further details than that. What else you have noticed apart from that is that Sophie has recurrent urinary tract infections, and these have occurred over the past 6 months. She reports pelvic pain, but did not want to undergo a gynecological exam. And you've also seen some mild bruises on her arms and shoulders. Sophie has mentioned occasional panic attacks and mentions that she has been prescribed antidepressants by another provider. She has also missed a few scheduled appointments in the recent months. So the GP notices, or you notice, that Sophie avoids eye contact when asked about her support network and hesitates when discussing relationships. Thanks, Jen. So maybe we start with Jen there. Jen, you can unshare the slide if you like. Thank you. What clinical indicators might prompt you to consider a trauma-informed response in Sophie's case?
So I guess in terms of the signs we recognize, there are very clear kind of mental health indicators, that ongoing anxiety, the panic attacks, the poor sleep, even after starting antidepressants, just being withdrawn, that feeling of overwhelm, avoiding eye contact, or avoiding discussion about relationships. We've got things like missed appointments, which suggests like avoidance or mistrust. That's often linked to trauma. And then you've got the very clear kind of medical indicators as well, which we mentioned before, which is the recurrent UTIs and that pelvic pain. There hasn't been a proper like gynecological review for it. She has the unexplained bruises on her arms and shoulders that may be from physical trauma. And then she has those potentially somatic expressions of distress, which is that persistent fatigue, the headaches, the abdominal pain, with no real clear medical cause. And because, all of these are appearing together, it's not just one indicator. That's a clear prompt to use switch gears. Let's take a trauma-informed approach now.
Thanks for that insight, Jen. Okay, welcome again, Anna. It would be nice to hear let's hear from you now as our lived experience expert, so we can deepen our understanding from what would have happened to you what was happening for you, what would happen for you in a situation at the GP. And I'd like to ask Anna, how can professionals avoid making assumptions while still being attuned to signs of distress?
There's a few things that I'm sort of thinking about here. The something that I just thought of while Dr. Jen was speaking just then was that two things can also be true at once. So she could actually have experienced violence, but also have like low iron or something like that. And I'm a survivor, but I'm also a social worker working at a medical service out here in Broken Hill. And it could actually be it's true of a lot of my clients that they've experienced violence, almost all of them probably, but they also all have low iron, and they also all have other medical reasons and things that happen. So I think that the questions about avoid making assumptions, and an answer to that is that the assumptions for the physical symptoms, we might be wrong about that. And I think the most important thing that you can do in working with survivors is be curious. And I'm talking about sort of gentle curiosity. I'm not talking about asking too many questions. And really, we don't need to know details about what people have experienced to actually believe them. It's usually not relevant to the way that we support people. And so it's just sort of about staying curious gently. And also, when we're asking questions about sort of using the language that Sophie's using and that survivors are using themselves. So in there it says in quotes that she said she's feeling overwhelmed. So you could, something like, you mentioned that you're feeling overwhelmed. Do you feel comfortable telling me a little bit more about that? Or, is there something that you can pinpoint that's making you feel overwhelmed? And like questions like that, but actually using the language that Sophie and the survivors themselves are using. And also in that curiosity, there's quite a few missed appointments there, and it'd be, an important question to ask, I think, why Sophie's been missing those appointments, but in a way that makes it very clear that she's not in trouble for missing those appointments, and you know, it doesn't inconvenience the service in any way. It's just that, you know, we care about you and we want you to be able to come to your appointments, and is there something that we can do that makes it easier for you to get to these appointments? And for me in Broken Hill, it's often things like transport, like there's no buses here, and so if people can't drive, then they have to be picked up, and if they haven't been picked up, then they won't make it to their appointments. So it's about kind of finding barriers for people, and for some people it's somebody won't let them come to the appointment, and then this is something that you have to really judge based on the survivor and their comfort level and the relationship that you have with people. If Sophie was my client and I knew her and I'd met her before, I would ask her about the bruises, and I would ask her really gently about the bruises. If it was the first time that I met Sophie, I might not ask her about the bruises, but it would really depend on the sort of the way that I'm connecting with her and how comfortable she is talking about the other things as well.
Thanks, Anna. And Robyn, yes, do you want to add something?
No, sorry. I apologise. I've got a mosquito buzzing around me that I keep flapping at.
Okay.
I'm very sorry. So yeah, sorry,
Okay.
Edmina,
Good.
I've distracted your
Good.
moment.
Anna, you mentioned that element of care, and we're here to care for you. So I think that's I want to throw that back to Jen, that element of care. Particularly as a GP, and like often we know that like there are businesses who operate in 15, 30 minutes time slots. How do you balance the medical care, that care element, and making space for the psychosocial concerns that you may be discovering in that consult in that time limited frame that you're working within in that consultation?
Yes, you've asked a very good question. So I look, this is basically where this is like trauma-informed principles in practice, and it will enable you to balance the medical care with the time restraints that you have for this person who needs a very sensitive approach. So I guess, you know, taking it back to those principles, starting, I guess, with safety, you want to I guess, acknowledge the symptoms that she's had or has been ongoing. So you want to acknowledge them, that they're actually very important and that you do want to address them. But also let her know it's up to her, you know, with what she wants to address in that in the consult. So make it as safe as you can in that room, and then you want to be really transparent as well. And you know, I'm very impatient. But I find it's actually very easy to tell someone that you have a time limit as long as you center their concerns and you make it genuinely known to them that you want to get to the bottom of their concerns. So you can just say, you know, we have 15 minutes. Be very transparent about it. I want to focus on your top concerns, and then I want to make a plan to revisit the other ones the next time. So be transparent with that. You also I guess you want to give choice as well. So you know, you want to say, okay, so what feels important for you to discuss today, and just let her know it's okay if she's not ready to talk about something. I talked about collaboration before. So you want to collaborate with making that list, for example, for future appointments. You're going to give her that sense of control as well. And then you want to and so lastly, I guess you want to empower her. And you can just say, look, you can acknowledge, because it did take a lot for her to come to that appointment, and she's there in front of you. And you can say that. You can say, look, I know, it's difficult actually getting to appointments, and you're here, and good on you. Here's my diary. When's the next time you can come in? Do you want to make that a phone appointment? You want to give her a bit more, let her use that autonomy as well. So I guess, yeah. So I guess in terms of balancing medical care, you need to let her guide the consult, and as well, with your expertise as well, but because she's only going to be interested in, I mean, like all patients, in discussing what's important for her. And even though it may not be important for you, you really need to be guided by her, because she's the expert of her own life, really. But yes, it's very, you can just say, we don't have much time. We've only got 15 minutes. Let's work on these things now, and let's book a long appointment next time.
Thanks, Jen. Just touching on that element of safety again, and Anna, I see a lot of nods from your side there on like that, because that was a very insightful answer, Jen. But I see a lot of nods from you, Anna. But from your perspective, going back to that element of safety, what might help someone like Sophie to feel safe enough to maybe share a bit more openly? So, yeah, can you tell us what might help someone like her to feel safe enough to open up more about her personal challenges potentially?
Yep. And the reason I'm nodding is because these are all, like, Dr. Jen, you just covered all the notes that I took for my answer. But I will repeat something just briefly to show that it's, that it is actually, this is the right answer, and this is exactly what a GP should be doing, because, I'm, validating it as a survivor right now. So the values that a GP can kind of create for safety in this space is it's the choice and control stuff. That's the trauma-informed practice. And I think something I wrote down for that is that showing the survivor that you're there, and also that you can't be scared. Like there's nothing that they can say that will scare you, because it happens all the time. In survivors are kind of like, well, I don't know that I can sort of share this with this GP because it's going to really shock them, and they're not going to be able to hold this, and they're not going to be able to handle it. And that's not true, in most cases, but we don't know that as survivors until we can tell that somebody is safe, and also that they're, they can hold this with us. And that's sort of not pressuring people to talk. And the transparency thing as well is so important. So it's being transparent about what you can actually do as a GP, particularly if you've only got a 15 or a 30-minute consult. And a lot of consults these days are just 15 minutes, and that's really not enough time to disclose sexual violence, recognize, respond, and refer. 15 minutes is really not a long time. The first 15 minutes you have with a survivor, you're very lucky if somebody would disclose something to you in 15 minutes for, first time meeting you. And most people don't really regularly see their GP either, like unless they have medical, things that they're managing. I see a GP, and my family members see a GP only a handful of times a year. So the likelihood that I'm going to, go and see my GP and disclose something is quite low. And it depends on sort of the way that they create the safety. The time, I did write the time limit thing down as well, letting them know how long the consult's going to be, and that, you don't want to rush them. If it's something they want to talk about now, then, of course I'm here to hear it. But if not, then we can, come back to it. We can book an appointment. My first available appointment is this time. You talked about it already in the presentation, but asking consent the whole way through the consult. So if you need to touch somebody, detailing exactly the way that you're touching them. So, I'm going to wrap this around your arm, and I'm doing this for this reason, and I need to know this for this reason, and sort of just talking through the way that you're doing that and why that's happening. and you know, making it really clear the sort of medical reasons why and why it's important, and obviously choice there as well, and consent from Sophie from the survivor for those like for the touching. I also reassurance about confidentiality. So, you know, we talk about confidentiality, we talk about this is a safe space for you to share your experiences with me. But as mandatory reporters, it's not really a safe space to share, because if they share something that concerns the, you know, the welfare, the well-being of the child, and there's a child at risk, then as mandatory reporters, we have to report that. And that's a breach of confidentiality. It's an important breach of confidentiality, and it has to happen to keep children safe. But it's also not really confidentiality. So I always share with people in the first instance that if you share something that you know, makes me concerned about a child, then that I have to do something about that. I'll always tell you if I'm going to make a mandatory report. We'll talk to them through the process together. And particularly working with survivors as well, you know, there's no shame, there's no bad parenting in having experienced violence, and really explaining that, you know, if I'm making a mandatory report, it's not because I don't think you're a good parent, you're a safe parent, you're keeping your kids safe. It's because, you know, I'm worried about the kid, but I see you as the protective factor, and explaining that in that you're here and you're seeking help and you want to leave, and, you know, whatever it may be, because you're trying to keep Bub safe, or you're trying to keep your child safe. But I do think that sort of that confidentiality kind of note in the beginning is important for people when they're sharing, you expect them to share about their children. And then the last thing about feeling safe as well is having a good understanding of services that exist that will be able to help people when they leave their appointment with you that day, that 15-minute consult. So having brochures and having an understanding, and people are a lot more likely to go to a service if the person who refers them to the service knows what that service does. So just saying, oh, you know, there's this hotline, you can call them because you've experienced this, but saying, you know, Full Stop Australia is an organisation, they're Australia-wide, they're available 24/7, they have trauma-informed counsellors, trauma specialist counsellors. That means that you'll get a counsellor who's worked with other people who've experienced what you've experienced, who knows how to hold that, you know, who has knowledge of the other services that exist, who can support you through this, and like actually having a kind of understanding of the sort of service landscape. So Full Stop and 1-800-RESPECT and maybe Lifeline or something like that is really important, and having that kind of thing available for people, because, you know, you see them for 15 minutes, however often it is, and then they have to spend the rest of the days and weeks not with you or another professional, and having, you know, access to something 24/7 is really important for that.
Thanks, Anna. It's interesting to hear from, like, you're a survivor, but you're also a social worker, so you wear two hats, and you can, like, probably see it from both, and like, but you have that lived experience. And so we already touched on it a few times, and like, I think we've mentioned all the elements, but just to ask that question anyway and stay in that lived experience space for a moment. What role do you think does the continuity of care play in supporting someone navigating, like, what often is very complex, not only what happened physically or like the outfall of like physical health issues, but also like what's happening emotionally?
Yeah, I think it's really important, and I recognize how difficult it is, and also, like, myself working in a rural area in an Aboriginal medical service where we have locum doctors every 2 weeks, it changes, and only, you know, 1 or 2 doctors that have been there for longer than a couple of years. It's, you know, it's really hard to get GPs in rural areas, and it's really hard to get continuity of care. But it's important for trust and creating safety. And it's also really important because, you know, as survivors, unless we're also medical practitioners, we don't know these things about our bodies, and we don't know that, you know, sort of things that are happening to us. And you see it all the time, people talking about feeling tired and they're just thinking they feel tired, but they're actually describing a kind of tired that's more than just lack of sleep, or talking about not being able to eat, or eating too much, or having nightmares, recurring nightmares that they wake up from, interrupting their sleep, things like that. Those are kind of ongoing health needs that an ongoing health practitioner can kind of monitor and support and manage with them. And the way that we try and sort of mitigate that out here is that we have Aboriginal health practitioners and nurses and other practitioners who are here for really long periods of time. And so that's the kind of continuity of care. So ideally it would be a GP, but where not possible, there are other practitioners who are there the whole time. And I often have clients, survivors and not survivors, who the first thing they'll say to me would be, okay, I'll talk to you, but only if you're going to be in Broken Hill for longer than a year. I'm not going to talk to you if you're going to be here for 2 weeks, because what the fuck's the point? Because I'm going to tell you everything, and then you're going to pass me to the next social worker, if we even, if you're even able to recruit one, because that also happens a lot out in rural areas. And so continuity of care is so important in that, like, building trust and rapport with people, and being able to notice what's going on with survivors as well. And the last thing that I want to say, which is not necessarily on continuity of care, but it's just an anecdote, it's a story from a client out here, and I want to tell it because it just shows how much of a difference a GP can make in a survivor's life. And it's a woman who came in to see a GP. She wasn't allowed to see any other practitioners, so she wouldn't be allowed to see a counsellor. Her partner at the time wouldn't have let her. The GP noticed something was up. He asked me to come into the consult. I came into the GP room. The partner was in the waiting room, luckily. But he would come, he'd come and he'd wait in the waiting room for her. And she disclosed domestic violence to the GP the first time she'd ever told anybody, because he noticed. And then she disclosed to me because he got her consent to bring me into the room as a social worker. And then we booked GP appointments weekly for the next few months, where we'd book the GP appointment, but it would be an appointment with me, but the partner would not know that, because she'd get a text confirming a GP appointment. And we were able to eventually extract her from the relationship, and now she's living safely with her daughter, not in the home with him. And then, he has no access, no contact with her anymore. That GP may have saved her life. Like, that's the effect of that. He noticed and he did something about it, and he was involved in the next few months of planning and organizing and supporting her. And she was able to leave. We had a police and DCJ and kind of group thing that we did, and they all came to the service that I work at, and they all came into the GP room, and the partner was sitting in the waiting room and he knew nothing about it. And she's living safely and happily, and her daughter is safe and happy, and that was all because of a GP who noticed something in the first instance.
Yeah, thanks, Anna. This would be an amazing opportunity to spruik our training for that CESPIN does for because the project is the DFSV, so we have domestic, family and sexual violence. I'm noting we're running out of time. I just wanted to get to Robyn for a minute, because there's so many touch points that you just explained, or that you touched on, about like there just being, sometimes it is only the GP, and we know that from research, and this is why this project exists, because sometimes or often it's only the GP that people can see or are allowed to see, and being able to recognize the signs is a really big part of then being able to do this work. However, we have the system that we have, or the project that we have, because we're not asking GPs to do this work alone. And Robyn, I just want to turn to you for a moment, because you can be online, you can be on the phone, you can do it with a patient, you can do it without the patient there, you can do de-identified consultations, you can assist people prior to someone coming in and talking through a case. Talk us through, Robyn, in the last few minutes, and I know it is 8:30. I know people have lives and probably need to leave at some point, but just to turn to that, because we're not asking GPs to be the expert in everything, and that support is here, and this is why we run this. So this is a particular resource for them to, or for you tonight online to turn to. Tell us a little bit about what you can do, and what strategies you walk people through with, and how can you help them to access support for Sophie and access services. Yes, talk us through, Robyn, please.
Yes, yeah, thanks so much, Nina, and yeah, thanks, Jen and Anna, especially for those insights that are so relevant. And I think the service that primary care providers, GPs, allied health can access through our service, DFSV Assist. You can see there's an email and a phone number. It is on two levels. It is the response to the patient. It is thinking about those things, as Jen said, sometimes those heart sink patients. I had a GP say to me, just when I have that really uncomfortable feeling when someone is left and I feel like there's indicators there and I wasn't sure what I could do or say, can I call you about those patients, and can I talk it through so that I can be prepared? And that's exactly an example of this service being beneficial. What the patient can receive from you is so important when you apply these principles and are open. And I think the second part of it is then also, as Anna touched on, there's that sense of coming across to the patient that nothing is a problem for you to say to them. Inside, you might be panicking and worried. What will I say now? How can I respond? Stay calm, stay calm. And some honest responses like, I want to assist you with this. You know, it's maybe by no means my expertise, but there's people who can help us, and together we can navigate what you need. And behind that for you then can be a call or email to get in touch with myself and my colleague to say, did I cover these things? They're coming again, the person I'm going to be seeing again, and I want to be prepared. I want to know that these are the things that I can offer, what's available. So far, the information I have is XYZ. And some of the concerns that, some of those things to reassure and give you the tools as well to then have the confidence in front of, to have the confidence with the patient and go through those trauma-informed care things. As Anna and Jen have both touched on, there's no one real thing that's going to be the answer. It is a process. There's lots of ways that people move through their journey and touch on different aspects. And so you just are never expected to be a person that has every answer and has everything available. Seeking that support to give this to the patients is what we can offer through DFSV Assist. So please take the opportunity and call us or email us, and we can also come to do the training in the practices, as I mentioned before too.
Thanks, Robyn. And in the interest of time, we've had a couple of questions which we'll hope to answer in our follow-up. We'll send you all a follow-up email. I think we'll bring it to a close. So I just wanted to say special thanks to tonight's speakers and for you all for attending. And just a reminder, please, to complete the online survey that will pop up in your web browser, as well as the post-training survey that will be emailed to you following the session. That will be wonderful. Thank you, Jen, for presenting. Thank you, Anna, for joining us tonight. Thank you, Robyn, and please reach out to Robyn with any questions you may have. Have a good night, everyone.